Welcome, everyone. I'm Dr. Mythri Shankar, Associate Professor in Nephrology at Institute of Nephrology, Bengaluru, Karnataka, India. Today, we're talking about monogenic kidney disease, that is, kidney disease caused by a single faulty gene. My main message is simple here. These conditions are far more common than most of us assume, and we miss them all the time. By the end of this session, you will know when to suspect a genetic cause, which big disease groups to think in, and how a genetic diagnosis actually changes what you do for the patient. Let's get started. Here's the plan for the next few minutes. First, I want you to appreciate just how common genetic kidney disease really is in both adults as well as children. Second, we'll go through the clinical red flags, the clues in the history, examination, and labs that should make you pause and think, could this be a genetic kidney disease? Third, we'll organize the whole field into a simple disease groups so it's easy for all of us to remember. And finally, we'll cover a practical testing approach. That is when to test, and importantly, how the result changes management for the patient. Keep the last point in mind throughout because this is not just pure academics, it changes patient care as well. Just to set the scene, chronic kidney disease is huge. Around 1 in 10 adults worldwide live with some stage of chronic kidney disease. More than 800 million people are affected with CKD at present. It's one of the leading causes of death globally and rising fast as well. Now, here's the point. Within this enormous population sits a group whose disease has a single genetic cause. They are hidden in plain sight, usually labeled as cause unknown. Finding them matters because for many of them, a genetic answer changes treatment, screening, and also helps in family counseling. With cascade testing, we can pick up more and more family members who could be affected with this genetic disease. So, why should a busy nephrologist care about genetics? Because monogenic causes explain a meaningful share of CKD across the whole lifespan, not just in kids. The numbers to remember here are roughly 10 to 30% of adult chronic kidney disease and 30 to 50% of pediatric chronic kidney disease has an identifiable genetic cause when you actually go looking for it. That's not a rare disease curiosity. That's a clinical tool you can use at bedside. Genetic testing has moved from the research lab to everyday nephrology practice. Let me stress the hidden part here. In adults with CKD, systematic testing finds monogenic cause in roughly 10 to 30%, even in patients who don't look obviously familial. In children, the proportion is far higher. But here's the problem. Most of these patients get filed under CKD of unknown cause and never undergo genetic evaluation. The disease is under-recognized, but definitely not rare. Here is real-world evidence in adults specifically labeled CKD of unknown cause. In one study, the whole exam pilot identified about a quarter had monogenic diagnosis. In another study, it was 17.5%. Think about that. 1 in 4 to 1 in 6 of your unknown cause patients may have genetic answers sitting there waiting for you to identify. This is the landmark recruitment study in the New England Journal. Over 3,300 CKD patients, exome sequencing done mostly in adults over 21 years of age. Overall diagnostic yield was about 9%. And remember, most weren't selected for being familial. Look at what drove the diagnosis. The collagen 4 genes for Alport, PKD1 and PKD2 for polycystic disease, and UMOD. Crucially, they found predictors of a positive result, which were cystic kidney disease, congenital kidney disease, CKD of unknown cause, and a positive family history. Those predictors tell you who to prioritize for testing. A more recent cohort makes the same point even more sharply. When patients were referred based on clinical judgment, so enriched by a thoughtful nephrologist and tested with focused 44 gene panel, the yield jumped to about 36%. And notice just 8 genes accounted for 95% of the diagnosis, led by PKD1 and PKD2. The lesson is powerful here. Smart clinical selection dramatically raises your diagnostic rate. Cystic, glomerular, and tubular phenotypes gave the highest yield. Now, let me show you our own data. This is work from our center, the Institute of Nephrology in Bengaluru, and I think makes the case better than any figure from abroad because it's us, our patients, and our practice. We tested 97 consecutive children and adults over 1 year, anyone in whom treating nephrologists suspected genetic cause and ordered a test. This was real world practice, not a hand picked research cohort, and the overall diagnostic yield was 45.7%. Nearly 1 in 2 patients walked away with an actionable molecular diagnosis. Let me give you a feel for who these patients were. The mean age was around 30 years, so a genuine mix of children and adults. About a quarter were under 18, two-thirds male. Importantly, this was a high prior probability group. 41% had a family history of kidney disease, and nearly a quarter had consanguinity. And most were sick. 6 in 10 already had EGFR under 15 when we tested. So this is late in the journey and not early. So there was no grant behind this. This testing was funded out of the principal investigator's own pocket, specifically to generate local Indian data, because genetic testing isn't covered by our national health schemes and patient pay out of pocket. That's part of why this matters. We are building the evidence base to argue for subsidized testing. So take home from this slide is simple. In our hands, in routine Indian nephrology practice, testing paid off nearly half the time. That's a yield that rivals investigations we order every day without a second thought. The yield wasn't very uniform, and let's see where it clusters and makes it clinically useful. Look at the top of the chart. Cystic and ADPKD disease led the way at 63%. Glomerular and syndromic disease close behind at 61%. Cacut at 60%, and tubulopathies at 58%. So if your patient sits in one of those 4 buckets, you should expect a real chance of a definitive answer. These are the phenotypes to prioritize. At the lower end, we have complement-mediated TMA and C3 glomerulopathy came in around 35% and nephron-ophthalmos ciliopathy around 33%. But the complement group tells the most interesting story. So let's just spend a few minutes on it. It was actually our single commonest reason for testing about a third of the cohort, and these were our sickest patients presenting with advanced kidney failure. Yet the yield was lower, and here's why. This group carried a heavy burden of variants of uncertain significance. More than half of all the variants we found across the whole study were BUS, and complement disease was a big driver of that. This reflects a real interpretation challenge. Indian populations are underrepresented in global genomic databases, so we more often land in the gray zone. 2 genetic points worth flagging here. First, across the whole cohort, recessive inheritance dominated about 56%, which fits our rate of consanguinity because of endogamy. Second, in the complement group specifically, CFHR3 to CFHR1 deletions were remarkably frequent. They made up to 40% of the variants in that group. That's a structural change you only catch if your assay looks for copy number and you back it up with MLPA, which ties directly back to the blind spots points. So sequencing alone would have missed this diagnosis. So the practical message here, know which phenotypes give you the highest return and know that complement diseases need careful copy number variants aware interpretation. Both should shape how you counsel patients before you send the test as well. The yield is not uniform. It clusters by phenotype, and this is genuinely useful. Cystic diseases and ciliopathies have the highest yield, often over 60%. So family history plus imaging should prompt early testing. Cacut is moderate to high. Test even apparently isolated cases. Glomerulopathies, including FSGS, are moderate, but yield rises sharply with young age of onset or steroid-resistant FSGS. Tubular interstitial disease is moderate and often missed as chronic interstitial nephritis. and even sometimes unknown cause CKD gives a meaningful 10 to 25%. So if the cause is unknown, look harder and do not stop looking. In children, the case is even stronger. Kakut is the leading cause of childhood CKD, and end-stage kidney disease commonly cited as roughly 40 to 50%. Copy number variants add further yield on top of sequencing. And a simple rule of thumb: younger the age of onset and stronger the family history, higher your expected genetic yield would be. So, in pediatric nephrology, thinking genetically should be by default and not an exception. Let me pull the evidence together into why this should change your practice. One, the diagnostic yield rivals tests you already order without a second thought. 10 to 25% yield is comparable to or better than many routine investigations. Second, a genetic diagnosis frequently changes management. It can stop unnecessary immunosuppression, enable targeted therapy, sharpen monitoring, and guide family counseling. Third, the word idiopathic should trigger a pause. Before you file a case as unknown cause, ask yourself, has a genetic cause genuinely been identified or excluded? Now let's make this simple to remember. The whole field fits into 6 buckets. First one is cystic encephalopathy like ADPKD and nephronophthosis. Second, glomerular, the collagen and podocyte diseases. Alport and nephrotic syndrome genes would come under this umbrella. Third would be tubulointerstitial like UMOD and MUC1 disease. Fourth, CACUT, the structural anomalies, HNF1B and others. Fifth would be complement mediated like complement mediated TMA. And sixth, metabolic and transport disorders such as Fabry, cystinuria, and Dent's disease. If you can slot a patient into one of these 6, you already know where to start. These are red flags that should make you think genetic, like early onset of disease, a family history, a consanguinity, multi-system involvement that a single common disease cannot explain, atypical or unexplained severity, or unusually fast progression, resistance to standard therapy or recurrence after transplant, and on histology, unexplained CIN, FSGS with no obvious secondary cause, or glomerular basement membrane changes suggesting collagen 4 disease. Any of these should lower your threshold to test. Here's a bedside cheat sheet, a clinical clue map. Bilateral renal cysts plus family history, think ADPKD. Persistent microscopic hematuria plus deafness, think Alport. Bland urine, slow CKD, and early gout, think of autosomal dominant tubulointerstitial kidney disease like UMOD, MUC1, or REN gene mutations. Steroid-resistant nephrotic syndrome with early onset, think of podocytopathy. Cyst plus retinal problems, maybe even liver fibrosis, could be nephronophthosis. Thrombotic microangiopathy, maybe complement-mediated disease. Angiokeratomas with neuropathic pain could be Fabry's. And renal plus urinary tract structural abnormalities could be CACUT. This is for rapid pattern matching. Always confirm with direct history and targeted testing. So now you don't have to guess at when to test. There is guidance for this. The National Kidney Foundation Working Group laid out clear indications to end a diagnostic odyssey before accepting a living kidney donor, a history suggestive of family history, atypical clinical course, CKD or end-stage kidney disease of unknown cause, a biopsy that suggests a genetic cause, atypical cystic kidney disease or liver disease, and a multi-organ syndrome of unknown cause. If your patient ticks any of these boxes, testing is squarely indicated. So this was one of our publications on when to do genetic testing in somebody presenting with glomerular hematuria. Here is a nice table and the reference is given here. If you're interested, you could go through the the flow chart. A good family history is our cheapest and most powerful genetic test, and most of us take this very lightly. Four tips. First one, build a proper minimum 3-degree pedigree and include the unaffected relatives too. The inheritance pattern matters as much as who's affected. Second, ask precise question. Has anyone needed dialysis or transplant in the family? These questions could catch far more than any kidney disease in the family. Just a question telling that is there any other kidney disease in the family? Third, screen for extra renal clues in the relatives like deafness, early cataracts, liver disease, sudden death, or unexplained strokes. Fourth, document consanguinity and ethnicity. Both change the probability of recessive disease and help in interpreting the test results. ADPKD is the prototype inherited kidney disease, the one everyone knows and the most common inherited kidney disease in adults. It accounts for 5 to 10% of all kidney failure patients. Two major genes, several minor loci. It's the disease that proves the point of this whole talk, a single gene, a clear inheritance pattern, and increasingly targeted management. If you're comfortable managing ADPKD, you already think genetically. So we just need to extend that kind of an instinct to rest of the kidney diseases as well. So here is a typical cystic case, a 38-year-old man referred for new hypertension with bilateral renal cysts incidentally detected on ultrasound, and a father who started dialysis at 52 with a cause that was never established. What should prompt suspicion? Bilateral multiple renal cysts on imaging, a first-degree relative with kidney failure of uncertain cause, and hypertension appearing before overt chronic kidney disease. That's a classic early ADPKD feature. This is a genetic diagnosis hiding behind a vague family history. So ask the right questions and it opens up to you. Alport syndrome itself, it comes in an X-linked form from col4A5 and autosomal forms from col4A3 and col4A4. The phenotype is a spectrum from thin basement membrane nephropathy at the mild end all the way to progressive Alport with kidney failure, even sometimes cysts in the kidneys. Same genes, very different severity. Watch for the classic triad beyond the kidney: hematuria and proteinuria in the kidney, sensory neural hearing loss in the ear, and eye findings like retinal macular spots and anterior lenticonus. When you see kidney plus eye plus ear, think collagen 4. A quick word on prevalence because Alport is more common than the textbook suggests. In a Singapore cohort of about 9,000, the genetic prevalence was roughly 1 in 165 for autosomal dominant form and 1 in 2,262 for X-linked, with Chinese individuals about 2.7 times more affected than the Malaysians. In Indian data, roughly 1 in 400 for the dominant form, with founder mutations in southern India. The key message: a lot of Alport is simply undiagnosed, hiding as isolated hematuria proteinuria, sometimes with a telltale hearing loss. Steroid-resistant nephrotic syndrome and genetic FSGS. The key genes here are NPHS1 in congenital nephrotic syndrome and NPHS2, that is podocin, a common cause in childhood steroid-resistant disease, and WT1 in syndromic forms, among others. Why does testing matter clearly? A genetic diagnosis predicts resistance to steroids and immunosuppression, so you can spare the patient months of ineffective and toxic therapy. And it's hugely relevant for transplant. Genetic or structural forms of FSGS have a much lower risk of disease recurrence in the graft than the idiopathic FSGS. That single fact can change the whole transplant conversation when you're speaking to the patient. Now I want to change gears a little. So far, we have talked about when to test and who to test, but here's something just as important. Even when you do order a genetic test, the test itself has limitations. A negative report does not mean no genetic disease. It only means the assay didn't find anything it was capable of finding. Some of the most important kidney genes are genuinely hard to read. and a standard test can walk right past them without identifying them. Let me show you three big blind spots. The first is pseudogenes. PKD1, the main polycystic kidney disease gene, sits right next to six look-alike copies of itself, sharing 97 to 99% of their sequence. Standard short-read sequencing struggles to tell the real gene apart from its imposters. UMOD has the same kind of problem. So a normal PKD1 result from the wrong method may simply be unreliable, not truly negative. Second, copy number variance. Some patients don't have a spelling mistake in a gene. They are missing the whole chunk of the DNA. The classic example is the HNF1B deletion, the 17q12 microdeletion. Sequencing only panels will miss these completely because they are reading letters, not looking for the entire missing pages. If your panel doesn't include copy number analysis, a real diagnosis can slip straight through. Third and the toughest, MUC1, the classic just sequencing failure. The disease causing region is long, repetitive, GC rich stretch repeated anywhere from 20 to 125 times. The standard next generation sequencing simply can't read through and reassemble it. So MUC1 kidney disease is routinely missed unless you order a dedicated and specialized assay for it. So the practical takeaway, if you strongly suspect a genetic cause for the disease and the test comes back negative, don't stop there. Ask your lab a simple question. What can this assay not see? Just a take home for this section, and please hold on to it. Negative genetic testing is only as good as the assay's blind spots. So think harder on every negative report. Ask what the assay could and could not see. And think even harder on every positive report. Make sure the variant genuinely explains the phenotype. The mirror analogy is deliberate. There's always a blind spot, and you only crash it if you forget it's there. Let's be honest about why this doesn't happen more in everyday practice. There are four real barriers. Low awareness of the genetic testing yield. Many of us underestimate how often testing is actually diagnostic outside of obviously familial cases. Access and cost, availability, turnaround, and price vary a lot by the setting and the region. Uncertainty about interpreting the results, especially the worry of managing a variant of uncertain significance or handling the counseling conversations. And time pressure. A proper pedigree is required, an extra renal examination. All of this definitely takes time in a busy clinic, which we may not have. Naming these barriers is the first step to start working around these barriers. Okay, we have almost come to the end of the session. I just want to walk you through a series of case reports we have published from our center, that is the Institute of Nephrology in Bengaluru, all of them on genetic kidney diseases. Each one started as a puzzle in the clinic. A patient who didn't quite fit, a biopsy that raised more questions than answers, or a family pattern that made us look harder. What ties them together is a simple idea that pushing for a genetic answer changes how we understand and sometimes how we treat these patients. Let me walk you through them, but I think I'll be very quick since we are running short in time. So these are our 10 case reports, which are already published in peer-reviewed PubMed indexed journals. Let me start with the one I'm most excited about because it's genuinely new to the literature. The aniline gene has long been known as podocyte gene. Mutations cause FSGS type podocytopathy. But we described two unrelated patients who presented with nephrotic range proteinuria, low serum C3, and biopsies showed C3GN, a complement-mediated disease. Nobody had linked aniline to C3GN before, so this is a first. It broadens both the clinical and genetic landscape of C3GN, and it hints that the podocyte and the complement system may be talking to each other in ways we don't fully understand. The next case is a beautiful example of the diagnosis The diagnosis is in the examination. If you look, actually, the nail patella syndrome is an autosomal dominant condition caused by mutations in the LMX1B, a gene that matters both for limb development and for the podocyte. Our patient's kidney disease had gone unexplained, but the clues were on the surface, the nails and the skeletal features. The genetic conformation of LMX1B defect tied it all together. This case, this case pair actually pushed us towards the complement pathway from a different, to look at the complement pathway from a different angle. Collapsing FSGS is usually a bad actor, aggressive, and often driven by things like viruses. We reported 2 cases where collapsing FSGS was C3 dominant on immunofluorescence, meaning the complement system was heavily involved here. This one is a lovely reminder that the kidney is part of a developmental story. We reported an adult with chronic interstitial nephritis who also had split hand, split foot malformation, a striking limb anomaly you notice the moment you shake hands. This another case takes us fully into metabolic genetics. Wilson's disease is a disorder of copper handling from ATP7B mutations. Most of us think of liver and the brain, but we reported a rare renal manifestation. The kidney can be a target too through tubular dysfunction and other mechanisms. A single gene metabolic disorder famous for other organs can present to the nephrologist as well. So if you keep your differential wide and remember that inherited metabolic diseases have renal faces, you'll catch the diagnosis that others walk past. So here, the patient presented with hypokalemia and muscle paralysis because of hypokalemia. And when we looked thoroughly, the hypokalemia was basically because of the Wilson's disease, which had damaged the proximal tubules because of the deposits of copper in them. And it was definitely treatable. This case shows how much one patient can teach if you keep digging. A 30-year-old man born to consanguineous marriage came to us with kidney failure. He also carried intellectual disability, developmental delay, type 1 diabetes, retinitis pigmentosa, a rotatory nystagmus, drooping eyelids, obesity, and low muscle tone. And that constellation should make you reach for the brain MRI, and it showed the molar tooth sign, which was the hallmark of Joubert syndrome. The whole exome sequencing sealed the diagnosis, homozygous nonsense variant in the AH1 gene causing Joubert syndrome type 3. This is again a beautiful lesson in why the gene sometimes has to overrule the scan. The senior Loken syndrome is a rare recessive ciliopathy, nephronophthisis in the kidney, paired with retinal dystrophy in the eye. So this patient was a 17-year-old girl from a consanguineous marriage who had polyuria, night blindness since childhood, now presented with advanced kidney failure with retinitis pigmentosa. So far, so classic for nephronophthisis, but then the imaging threw us a curveball. Instead of small scarred kidneys you expect in nephronophthisis, her kidneys were enlarged, 14 centimeters, with a diffuse salt and pepper microcystic pattern. Now that salt and pepper pattern looks almost like a fingerprint of autosomal recessive polycystic kidney disease. But when we did genetic analysis, it turned out to be senior Loken syndrome. So this brings us to the proximal tubule and to the metabolism. Fanconi-Beckel syndrome is rare autosomal recessive disorder, collagen storage disease essentially caused by variants in the SLC2A2 gene, which codes for the GLUT2 glucose transporter. So this was a novel mutation identified in a suspected case of Fanconi-Beckel syndrome. The last case, one of the most rewarding because it doesn't just diagnose a genetic disease, it shows what happens at the far end of the journey at transplant. Bartter syndrome is a group of inherited salt-losing tubulopathies. The kidney's thick ascending limb can't handle salt properly, so patients waste potassium and become alkalotic. So there are 6 types. This patient was diagnosed in adulthood with homozygous missense KSNJ1 mutation and had a telltale feature of uremia, hypocalcemia, and medullary nephrocalcinosis. And usually the disease progressed all the way to end-stage kidney disease. And here's the headline. After a period on dialysis, the patient received a deceased donor kidney transplant, which worked beautifully for him. Finally, hypocalciuric hypercalcemia, a familial hypocalciuric hypercalcemia caused by variants in calcium sensing receptor gene. It's usually thought of as benign, high calcium, low urinary calcium, and you just leave it alone. But we reported a patient in whom this disorder was associated with AKI. A reminder that these calcium handling genetic conditions can bite the kidney. The clinical value here is about avoiding harm. If you mistake FHH for primary hyperpara, you might send the patient for unnecessary parathyroid surgery. Recognizing the genetic condition, the family pattern, the low urine calcium stops you from doing the wrong thing and alerts you to watch for the kidney. So, pulling all the threads together, because these cases teach the same lessons from different directions. First, the clue is often outside the kidney, the nails, the hands, and the feet, the calcium, the copper. Extrarenal signs pointed the way in almost every case. Second, the biopsy and the gene work best went together. Our aniline and complement cases only made sense when we read the pathology and the genetics side by side. Third, a genetic label changes something real. Family counseling in dominant conditions, avoiding unnecessary surgery in familial hypocalciuric hypercalcemia, considering complement targeted therapy in C3 cases, and treatment in Wilson's. Fourth, these were all findable in routine practice in a real Indian tertiary care center once we decided to look. So that's the whole point. So that's the collection. These case reports one message. Genetic kidney disease is hiding in your clinic, and it declares itself if you keep your eyes open on the examination, on the kidney biopsy findings, and also in the family history. Each of these started with a single patient who didn't fit the mold. I'd encourage all of you to write up the cases that puzzle you because that's how the field grows. One careful, curious observation at a time. Thank you so much, and I'm happy to take any questions.